My name is Doug Lane. I'm a geropsychologist here in Tacoma, Washington, so the little sibling to Seattle, where it is indeed about 66 degrees and sunny. So they say that we endure the winters up here to enjoy the summers. So we're doing that today. So my talk this afternoon, it's afternoon for you folks, I know, is on the differential diagnosis of delirium, dementia, and depression in older people. This is sometimes what's referred to as the 3Ds. So we talk about the 3Ds and differentially diagnosing the 3Ds. I suppose you could call that the 5Ds. But so in terms of learning objectives, well, actually, let me talk about my disclaimers first, real quickly before I get to the learning objectives. This is the standard stuff. The content here is not reflective of the opinions or perspectives of the University of Washington or Shanagee Psychological Services, who I practice with here in Tacoma. It's just my ideas and my input. It is presented only for general educational purposes, so I would never presume to offer any kind of specific clinical input on a case or diagnostic input on a case. I would never presume to try to step into that role. Certainly respect the fact that decisions about clinical care reside with the clinician exclusively. So learning objectives, and I'm going to move the window that has the chat in it so that I can see those. Are you guys seeing the chat superimposed on the slides by chance?
No.
No.
We're
Okay.
seeing the
Good.
learning
Good.
objectives.
Okay. Good. Okay. So learning objectives. Wanted to talk some and help you understand the role played by ageism in complicating the identification of depression and delirium and dementia in older people. Help recognize some of the key features of depression, delirium, and dementia in older people, and help identify some of the areas of overlap between these syndromes, but also their unique features. So let me do that. Okay. Well, let's see. There we go. So to begin with, just some general guiding principles when it comes to working with older people. And these are both actually quotes from the chief of geriatric medicine that I most recently served under in the geriatric medicine service for the VA healthcare system here in Seattle, Tacoma. She used to say that geriatrics is both the art and the science of managing complexity. And at other times she would say that Occam's razor is not sharp enough to shave an older person. And those of you who are familiar with the principle of Occam's razor, it's simply that the most basic or straightforward solution is probably the solution or the explanation. But what I have found in working with older people in general is that Occam's razor sometimes can become an erroneous form of clinical reasoning rather than a helpful form of clinical reasoning. And if we get lost on the notion that there's probably a simple explanation to the syndrome that we're facing or treating, we're probably going to miss something when it comes to working with an older person, because we're managing complexity. And there's both science and also art to that. Second guiding principle is that of diversity, and I've included a quote here, two quotes, one from a long time ago, one from much more recently. The first one from Plato, essentially just saying that the greatest mistake that we can make in treating a human being and treating medical conditions is to not recognize that people are both body and mind, body and soul, as Plato says, and that the two are intertwined. So in more modern terms, our emotional and cognitive processes, and indeed our existential processes, are intimately tied and intersectional with our physical health. And if we're not attending to all of those different aspects of a person, then again, we're missing something. Furthermore, building on that, this is a quote from Advent Health University, that patients' backgrounds and experiences often influence how patients understand their own health, their relationship with healthcare providers, and their treatment. And the notion that I take from this is that this relationship between mind and soul and cognition and body is both universal to human beings, but it also varies quite widely in its expression based on the many aspects of human diversity. And so, again, part of taking care of a person, including an older person, is understanding all the diverse aspects of that person and how those intersect with the aspect of their age. There we go. So third guiding principle, what I refer to as anti-ageism. So I referenced ageism earlier. For those of you who haven't come across the term, it dates to about 1969, which for some of us is not that long ago. But so it's pretty new, and it came out. It's no mistake that it came on the scene during a time of a lot of social and equal rights work that was being done in the country. And a geriatrician by the name, I'm sorry, I'm just checking the chat here. I just realized if there are questions and you do have them, hang on to them at the end, till the end, and then I can get to them. But I wanted to make sure I wasn't missing anything there so far. But yeah, ageism was coined by Dr. Robert Butler, who was a geriatrician, and as the name might imply, it refers to as stereotyped views, biased views, and then resulting discriminatory behavior based on age. It can actually affect either end of the age spectrum. You see it directed at younger people, just like we do at older people. The topic here today is older people, so I will focus on that. But just know that it can go either direction. You don't have to go very far, other than like TikTok or somewhere like that, to see the memes going back and forth between, Generation Z and the baby boom generation, just as a pop culture manifestation of that. But these are a couple of quotes that I just thought really captured it all. And this is from a psychologist named Kristen Weir, who wrote an article about this in 2023 in the American Psychologist. And she said that ageism is discrimination against older people because of negative and inaccurate stereotypes. And it's so ingrained in our culture that we often don't even notice. This is quite true of mainstream media. You see these ideas come out all the time. You see it in smaller places. You see it in larger places. It's one of those things that you don't even notice it until, as she said, until you start looking for it, until you start paying attention. And then you see these prejudices and these stereotypes begin to show themselves. She also referred to it as one of the last socially acceptable prejudices, which I thought was an interesting observation. And, I think speaks to the fact that it is so prevalent that there aren't very many people challenging it or saying this isn't right. Beyond, though, being, certainly rude to direct towards someone, ageism represents a violation of medical ethics, and specifically the notion around non-maleficence. And this is an ethical dictate shared by all medical care disciplines, regardless what they might be. We have an ethical obligation to respect the principle of non-maleficence, which simply means first, do no harm. Ageism causes harm, and it can do it there are informal ways it can do it. So I might meet with an 82-year-old and recognize that she has some memory loss, but rather than really getting into that or trying to investigate that, I just kind of assume, well, sure, she's 82. Old people can't remember things. And so I just kind of write it off, don't really get into it, consistent with age. That's all I really write down about it, when in fact it may not be. There may be a reversible etiology, for example, and it may be greater than would be expected with age, and we need to know that in order to diagnose a syndrome and prepare to manage it. But we also see the harmful effects of ageism coming out in a more formal way. This is a concept stereotype threat that actually comes from some of the larger literature on human diversity. But essentially, it's the notion that if I belong to a group, if I'm a member of a group, and I'm very identified with that group, and I, over time, get message after message denigrating that group, stereotyping that group in some way or another, I will, drop by drop by drop, incorporate and internalize those stereotype views and apply them to myself. A term for this is called internalized ageism when we're talking about older people. There's an interesting study, I'm glad to share it if anybody wants to write and ask me about it, in JAMA not too long ago, talking about just how common internalized ageism is, and it's frightfully common among older people. And what does it do? Well, if I, as an older person, have incorporated these ideas that I'm kind of in the way, that I teeter on the edge of becoming a burden, that I don't have much to offer, that my memory's probably going, that I'm just sitting around and waiting for the next thing to go wrong with my body. If I incorporate those kinds of views of what it means to be old, it's gonna predispose me to depression. It's going to predispose me to increased mortality and morbidity in other ways. It's going to influence my decision making when it comes to signing an advance directive. It's going to influence all kinds of things adversely. And so, as I say, ageism is actually a violation of medical ethics as well as just being unkind. So important to keep that in mind. And then the last guiding principle, networks. Working with older people means necessarily, and when I say necessarily, I mean good standards and practice. It's necessary to do this, to work with their networks. A term that's popular up here in the Pacific Northwest, because we have a lot of whales, is we need to work with their person's pod along with the person themselves, because we all do. We live embedded in marriages, families, which means friends who are family, partnerships, work relationships, you name it. I just listed a few, but there are multiple examples of the networks, social networks, interpersonal networks that we live in. And those folks can be vital in diagnosing and treating and differentially diagnosing the syndromes that we're talking about. Because a term you'll hear me hit a lot as we go through these is baseline. What is the person's baseline? How is this person most of the time? And as clinicians, if we don't know the answer to that in good detail, we run a high risk of making a misdiagnosis. So the folks and the other whales in the pod are critical to get to know from a diagnostic standpoint, but also from the perspective of people that we might need to look out for too, because these are the folks who are going to be potentially helping us take care of the person who's our identified patient. Their spouses, intimate partners, adult children, friends, whomever, are the people that we'll be looking to help us out. But we also need to know that this is stressful on those folks too. And we can have a role in helping look out for them, especially working with very challenging illnesses like the 3Ds. And you'll see at the end of the talk, there's a reference article that I mentioned that actually specifically talked to family members about what it was like for them to have a loved one go through a delirium and talk about the effect of that on them. So, and then my last guiding principle is diligence. Because this is a complex population, because we are diverse people as it is, and then when you add age on top of it, well, that just adds one more bit of spice in the gumbo that we all are. And because these are complex diagnoses, we need to be diligent. So it's not uncommon at all, and I've seen this in countless circumstances over my years in geriatric medicine, to see that cognitive and mental health function was not proactively or thoughtfully evaluated as part of a routine examination. Very, very common. And a number of systemic reasons that happens, among others, time. I only have 20, 25 minutes in my clinic appointment, for example. Very common. Other times, though, that I've seen it happen, it was because of ageism. And again, seeing some things that might be a concern, but they were just written off to age. Or they weren't even asked about because the assumption was that doesn't happen to older people. So something to keep an eye on. To put it in maybe a little more succinctly, when we read a chart and someone's cognition is described as being W and L, that can mean within normal limits, or it can mean we never looked. You just never know. The reason this is so important is because early detection of these kinds of concerns is unlikely unless we specifically and objectively assess. Simply talking to a person for 15 or 20 minutes is not adequate to gather the kind of data necessary to really diagnose these syndromes and differentially diagnose these syndromes. Our clinical interviews are notoriously inaccurate sometimes when we look at our conclusions, especially the shorter that they are, the briefer that they are. So as a result, we may very well be underdiagnosing or undiagnosing some of these syndromes. They leave people with an increased risk of morbidity and mortality. And if we misdiagnose, then we might be treating something that we think is syndrome A when in fact it's syndrome B. So we might be causing more problems than we're solving, especially because these syndromes don't necessarily occur in isolation. Sometimes, for example, you could have a person with dementia develop a delirium superimposed, and the effects of that can be synergistic. And so if we don't have a good, clear sense of diagnosis and we mistreat, then we could clearly make things worse. So, to put it all together in a bow, the proactive assessment of cognitive and mental health function is a crucial step in ensuring that the person's overall health and well-being is addressed, no matter what other medical issues they face. So, getting some idea of these factors is part of an overall geriatric evaluation, and sometimes what's referred to as a comprehensive geriatric functional examination. So moving more specifically then with those general points and applying them to the 3Ds, I start with delirium. And you'll see as you go through charts or you talk to providers, you'll see it referred to by a number of names. And that's part of what makes this complicated is we don't have one single universally recognized name for it. Delirium is the most common name, but you will hear sundowning used a lot. You'll hear terms like ICU psychosis or post-surgical psychosis, altered mental status or AMS, toxic metabolic encephalopathy, there's a mouthful, acute brain failure. So delirium is viewed as sort of the acute version of organ failure, just like you can have acute kidney failure. So we've got acute brain failure. But sometimes it's not identified by a name. It's identified by an experience. And I have heard this many times over the years. Mom's or dad's dementia has just been so much worse this week. Last week he was himself, or last week she was herself, but in the last few days, we can't get her to respond. She doesn't talk as much. She just sits and stares out the window. She seems more confused. I guess she's just having a bad week with her dementia. So there's not even a label applied to it. It's described, and I immediately in those situations say, that's not dementia. That sounds more like delirium, and I'll show you why. So it is an old adversary. I like to say that working in geriatrics is facilitated if you happen to be a bit of an amateur historian, or you like to geek out on history like I do. But delirium is not a new concept, and this is at the time, what would have been considered a physician in the first century AD, talking about sick people being in a febrile, going through febrile paroxysms, losing their judgment, talking coherently, becoming agitated. It sounds a lot like an agitated delirium. It's what they were seeing then, and it's what we see now, just under different title. So I want to highlight, and this is why I start with delirium, just highlighting these 2 points at the top. A delirium is an urgent medical condition. Someone who's developed symptoms of delirium, they should be considered in an urgent medical state, and therefore should get urgent medical attention. I'll show you here shortly some of the potential causes for a delirium can be quite dangerous. And so this is why I start with delirium. Among the 3Ds, if we triage them in terms of dangerousness, delirium is the most dangerous, head and shoulders above the other two. It also, defining factor, represents a distinct change from baseline. And again, this is where our family, loved ones, friends, etc. are so key. What is this person's baseline? Last week, Dad was fine. Dad was himself. This is not my dad. My dad has dementia, but this is not my dad. Okay, I need to know that. I have seen cases, and I've had to deal with cases where a person who developed delirium went into the hospital, say for pneumonia. The hospital did not adequately assess, and the person was discharged with a diagnosis of dementia that they never had, because the hospital confused delirium symptoms with dementia. So delirium is a distinct change from baseline. These are the diagnostic criteria from DSM-5. Pretty straightforward. Disturbance of attention and arousal, disturbance in other areas of cognition, specifically memory, language, perception, orientation, visuospatial skills, the basics. Another key feature, though, is it develops over a short period of time, usually hours to days, and it fluctuates across the course of the day. Dad was doing so much better last week, but in the last couple of days, he's really been struggling. In the morning, it's been easier to talk to him. In the morning, he's like his old self, but boy, by the afternoon, he's just gone. So these kinds of things, again, the diagnosis sometimes isn't even given a word. It's described as an experience, but you recognize this is a diagnosis. This is not part of something else. Delirium is differentially not explained by another pre-existing or evolving neurocognitive disorder. So it is different from dementia. It's not just having a bad day with dementia. It's not that. And as I say, it's directly caused by a medical condition, and I'll show you a list of those here in a second. But first, some prevalence rates. I won't go through these line by line. The take-home point from having them here is that it's common. It's probably more common than we realize, and you see certain settings in which it is remarkably common, maybe not unexpectedly, like the ICU, emergency rooms, long-term care facilities, general med-surg, inpatient floors, places where older people end up a lot, and people with dementia end up a lot. And so the prevalence rates in those settings is noteworthy. As I say, it is considered an acute condition. So generally, speaking broadly and generally, once the underlying offending mechanism is treated, then the person's cognition will hopefully clear and things will be okay. However, it can persist sometimes for weeks and even months. Even after the cause has been addressed, the cognitive symptoms can linger. And so Not surprising, for example, when I was doing nursing home care, I would have people who were admitted acutely, say for pneumonia or a UTI with delirium, come back in a week or 10 days on a course of antibiotics, say, but still be delirious. Even though the antibiotics were over, they finished those up, and theoretically their labs were clear. The confusion persisted. So especially in an older person, it's not uncommon for the confusion symptoms to stick around. And so on discharge from hospital, it's something that we always encourage people to look at. Great, my loved one doesn't have a UTI anymore, they're not septic anymore. That's really good. What's their cognition like? Because we can't make any assumptions. And some people, and I've seen some cases of this, will develop post-traumatic symptoms after a delirium in response to having had the delirium. For example, I had a most recent case of this was a person who had had very violent hallucinations and deep paranoia in the emergency room about security personnel in the emergency room, thinking that they were going to kill her, seeing their faces turn into sort of demonic looking faces. And even after things had cleared and the person was well again, they still had a very pronounced startle reaction if they happened to see like a police officer or something like that, and they'd have to leave the room. So you can see some of those post-traumatic symptoms after a delirium. It speaks to the notion that there's a lot of psychological recovery from delirium, whether it's a trauma response or any other kind of response. There's a lot of psychological recovery that needs to be done after delirium, just like there is treating the medical issues. A term sometimes you'll hear used for this is ICU PTSD, which is finding its way more and more into the parlance. So I mentioned some potential causes of delirium. I won't go through these line by line. The take-home points, 2 points. One is that there's a bunch of them. There's a bunch of potential causes. So, saying, okay, well, we ran a urine and everything looked good. Well, that's good. That tells you it's not that. But there's a whole bunch of other things that need to be looked at. This is where that diligence comes in. And I've seen a lot of times where, well, we ran a urine and the urine was good. Great, but this person is still confused and we don't know why. We know it's not urine, it's not a UTI, but we don't know why. So there's a lot of different things that can do it. And just underlining the point, that some of them can be very dangerous, which is why delirium is considered an urgent medical condition. So I want to talk a little bit about the presentation of delirium. I want to put the rubber on the road and think about some concrete things you might see at the bedside, so to speak, or at home or wherever you're interacting with this person in their day-to-day life when they develop a delirium. So you may see waxing and waning, a very somnolent or obtunded presentation, withdrawn, reduced activity level, reduced responsiveness to their environment, lethargic. In general, slowed information processing speed, so it seems like it takes them a while to think through what they're trying to say. You can have the other side of that coin, though. You can have someone who is very agitated. Their behavior is very disorganized and chaotic. They may be combative. In any case, very common for them to be disoriented, to time, to place, to circumstances, to also not only not know where I am, but not know why I'm here. So to not understand that I'm in a hospital, or if I know that I'm in a hospital, to not understand why I'm here, to think I'm being held here as a prisoner, to not understand that I'm sick. My favorite diagnostic story here came from an intern of mine who knew a person with dementia very well, and he was completely disoriented except a person, but he thought he was in Rhinelander, Wisconsin, which was a place he loved where he had grown up. And he developed a delirium with a UTI, and the intern picked up on it when she saw him one day and did a mental status check and he said he didn't know where he was. And she came to me, and sure enough, he had developed a urinary tract infection. Just an example of where knowing baseline is key. But even where sometimes in a person who's disoriented at baseline, they can become further disoriented, and that can tell us that there's a problem. The diagnostic criteria reference that deficit in attention, so you can see, and this is complex attention like what we're using now in a conversation, but it can also even include simple basic attention like the ability to acquire and focus on a new stimulus, like someone coming in the room. So you can see the person having trouble staying on topic in a conversation, as if they can't track their train of thought. They can't focus long enough. Or you can see them hyper-focused. You can see perseveration such that the person doesn't have the ability to transition from topic to topic during the conversation, and they keep going back to a topic as if they're stuck on it and you just can't move them off of it. They may be easily distracted by unimportant stimuli like a noise in the hallway, or the color of the doctor's pen, or the color of the nurse's shirt, or something like that. So again, difficulty mitigating distractions and at the same time staying focused on what is most pertinent. For all of these reasons, memory, especially recent memory for recent events, will often be affected. They may confabulate, and confabulation is not lying. The human brain is driven at a very instinctual level to maintain a narrative of what's happening, what's going on, what led up to this, what's coming next, what's happening to me, what's happening to people around me. And when the data to do this is lost because memory systems are not encoding, then our brain tends to kind of put together what it can to come up with the best narrative that it can. And so you get confabulations out of that, confabulated memories. My computer, there we go. It keeps giving me trouble changing slides. Let me know if for any reason a slide doesn't change. You can see difficulty speaking or recalling words. You can certainly see rambling and nonsensical speech. So the person that's hard to interrupt, can't stay on a topic, saying things that are nonsensical, using words that are nonsensical. Also trouble understanding what we're saying to them. So for example, difficulty following instructions because they don't understand what we're asking them to do. And that could include whether we're asking them verbally or whether we're trying to say, well, here's a sheet of instructions, can you do this? They may have trouble reading as well, and staying focused long enough to read, even if their brain could parse apart the language. Lastly, though, and I've seen this so many times, is just this sort of more generalized, and you see this a lot like in inpatient settings, for example, this very generalized calling out, moaning, making other sounds, and what I call the call bell sign. That has sometimes been the most, the initial and most powerful suggestion that someone had developed a delirium, is when they would start ringing the call bell a lot, and when staff would attend to them and say, what's up, how can I help? They would say, I don't know, I need help, I don't know. And well, what's wrong? I don't know. And then 10 minutes later would be ringing the bell again, and the same response, I don't know what's wrong. So sometimes, it's that subtle, but astute staff will pick up on it. And let's face it, nurses are rock stars, and they pick up on that stuff. And then disturbed sleep habits, either sleeping a whole lot, or during an agitated delirium, especially staying up all night long, or sleeping for a few minutes and then being awake and agitated, and on and off and on and off. And those of you who are in sleep medicine or know what that does to brain function know that distorted sleep just takes a brain that's struggling and makes it struggle even harder. This slide actually, though, up till now, folks have probably kind of been, on board, probably heard of this, seen some of this stuff. But delirium can also present as a marked change from the person's mental health baseline. So sometimes it presents with mood changes in the direction of anxiety or depression or irritability. There's a phenomenon referred to as a manic delirium, where the person can present as if in a manic phase, with the exception that they have the disorientation and the cognitive confusion. You can see mood lability, can see personality changes. I've seen situations with people who are in deliria become suicidal. And certainly, as I mentioned, in the most extreme cases, the person can begin to develop hallucinations in any sensory modality, as well as delusions. So not just visual hallucinations or auditory, but tactile hallucinations, gustatory hallucinations, or olfactory hallucinations. Any and all are possible. So as I've kind of alluded, there are three sort of recognized clusters, if you want to call them that, of types of delirium. You have the hyperactive, literally that's the term for it, hyperactive delirium, where you see the increased psychomotor activity, the hypervigilance, the restlessness, the agitation, the mood lability, hallucinations and delusions. There's also a hypoactive form, where you see the decreased psychomotor activity, more the lethargic, the drowsy, the apathetic presentation. But most commonly we see both. So sometimes of the day more lethargic, sometimes more agitated, and waxing and waning between those two extremes. So I've listed some risks and exacerbating factors here, and again, not to go through all of them line by line, but just to make a larger point, which is that if you think about working with older people and you run through these items, you'll start to see how many risks I have for delirium, say, for example, simply because I'm 85 and I have a few medical problems and I take some medications, and perhaps I'm already experiencing some cognitive loss. So a lot of our older folks that we take care of are at a standing risk for delirium. It's just there. And again, if you look through this list, you'll see why I say that. I do want to highlight, I don't know if we have any vision or hearing specialist providers in the audience, but I want to say thank you to them if there are. Sometimes one of the most important avenues for treating and helping with delirium is working with vision and hearing, because if the person's not able to see or hear very well, that's going to complicate delirium exponentially. Related, it's pivotal in helping a person live with and manage dementia symptoms as well. Going back to that notion that we all live in networks, and this is an interdisciplinary process. So just I mentioned our clinical interviews are good, they're necessary, they're not sufficient. Can be very helpful to use some of these. These are just some commonly established measures for helping us think through a diagnosis of delirium. I do want to highlight the family confusion assessment method there. Again, speaking to that notion of we live in networks. This is data you can gather from the family to help get a sense of baseline and how the person has been doing. And so while I want to encourage people to use these things, I don't want to encourage people to use them instead of a clinical interview. By no means we want to do both, and not rely too much on one or the other. So get some objective data, get a good clinical interview, labs, etc., and that will help you make your diagnosis. So moving on from delirium, major depression. I have listed the symptoms here, excuse me, as per DSM-5. I tweaked them a little bit for older people. Um, Certainly the classic, so to speak, is this refractory depressed mood, which is more than a normal low. It's pervasive times 2 weeks or more. Um, there is it's called anhedonia. There is a loss of interest and pleasure in doing things that I normally enjoy, but also on a deeper level, a disengagement sometimes in key relationships in my life, or other more meaningful aspects of my life as well. So I begin to lose sight of the things, the values, the principles that give my life a sense of purpose. But the important piece is that these are all unrelated to medical or pragmatic barriers. So I've quit going to meet with my old friends, but it's not because I don't see the purpose in it anymore, and because I'm depressed. It's because my back pain is too bad, or it's because I can't afford the shuttle to get me there anymore. So those are problems in and of themselves, but they would not be considered depression, and we would help them in a different way. Appetite changes, again, unrelated to dieting or other medical issues, GI problems or things like that can cause appetite changes. Sleep changes, too little, too much, unrelated to medical issues like chronic pain, for example, or nocturia, things like that. Loss of energy and fatigue, likewise, not due to medical factors. Restlessness or slowed movements, what's referred to sometimes as psychomotor slowing or psychomotor agitation, again, not due to other medical causes, like, for example, side effect of a medication, say I'm taking a steroid, for example. Feelings of worthlessness, hopelessness, excessive guilt. These are what I refer to sometimes as the existential symptoms of depression. And the developmental challenges, normal developmental challenges in later life, bring us into a very existential space if we haven't been in one already. And so that's where sometimes these feelings can emerge. And so sometimes we talk about, informally talk about an existential depression, or these kinds of things are predominant. They can lead to thoughts about death or suicide. That is a hallmark symptom of depression, no matter what. And again, these symptoms represent a change from previous level of function. And again, as I've mentioned above, we're being careful to be aware of medical mimics. So especially with older people, a medical factor which can cause a person to look depressed when in fact there's another medication or medical issue involved. These are some of the unique features that differentiate a depressive episode from the other two Ds. The person may well have a previous history of depressive episodes, and you can look around especially to see, is there a current psychosocial trigger that might have precipitated a depression? And it could be something like, a relationship problem, or it could be something on the surface that looks like it ought to be good, like grandchild just got married. Has there been any noteworthy psychosocial event that might have triggered something? As I mentioned, people when they're depressed oftentimes will have a predominance of mood and existential symptoms versus some of the other things. And depressive episodes, their onset is insidious. It's not over a few hours or a day or two. It's more insidious than that, over usually like a week or two. And it doesn't fluctuate. Sort of by definition, the person is depressed and down most of the day, nearly every day, day after day, to quote the criteria. They can maintain a consistent level of alertness. So the person may be psychomotorically slowed and fatigued and just not have a lot of energy to do much, but they are alert, they are attentive, and they're not disoriented or confused. They can recall events that have been happening. um, and can remember things they need to remember, especially if they're given cues to remember those things. And that has to do, which I won't go into, but that has to do with the neuropsychological differences between encoding deficits in depression versus encoding deficits, for example, in something like dementia, and how those processes are different. People who are depressed don't have changes in language ability. They do have preserved insight. They can carry on a conversation. Their behavioral organization will be preserved. So they may not do much, but what they do will be organized and efficient. And depressed people are generally not combative or agitated. So some differences there. Another way to think about it, and this is the intersection of, we're going to intersect this slide with my previous slide about prevalence rates in different settings. This is some data from SAMHSA 2021, and you'll notice kind of right in the middle, the columns for age, that the prevalence rate for major depressive episodes among U.S. adults in 2021 was lowest among people 50 and older, 4.5%. So if you notice, you're much more likely to experience a major depressive episode if you're a young adult versus an older adult. And if you combine that with the data on prevalence rates, where especially in certain settings, if we think about the interaction of age with setting, if we have an older person who's in, say, a medical surgical ward and we're seeing some changes, it's more likely, just on base rates, it's more likely to be a delirium, for example, versus a depression, or at least that's the first place we would want to go. I actually recommend always going first to delirium. If someone shows up with a change in status, an acute change in status, always go to delirium first until proven otherwise. But definitely if we're in like an inpatient hospital setting and we're working with an older person. Sometimes people with major depressive episodes do develop psychotic symptoms as part of that. Older people are somehow more prone to develop psychotic symptoms. Some things that can differentiate that piece of it. People who develop psychotic symptoms now are more likely to have had a history of prior psychotic symptoms in their past. They're, again, like a person who's depressed, less likely to be disoriented. They may be carrying on delusional activities, but they're oriented. They know where they are, who they are, etc. They will be able to maintain arousal and alertness unless they're under the effects of a sedating medication like an antipsychotic. Their symptoms will be more consistent, just like a person with pure depression. They're not going to wax and wane like a delirium would do. First onset schizophrenia is actually rare in later life as well. It does happen, but it's much less likely, speaking to base rates. So it's much less likely that I at 85 will develop paranoid schizophrenia versus that I'll develop a delirium. And as always, beware the medical mimics. These are some common instruments we use in assessing depression in older people. I'll note the Cornell scale for depression and dementia, which is really helpful if the person is not able to cognitively participate in an interview about their mood status. It's kind of a nice structured interview. And I also threw in a measure for anxiety, because anxiety and depression often go together like salt and pepper, especially in older people. So final section, major neurocognitive disorder, aka dementia. I've listed the criteria here, again from DSM-5. Here we're talking about substantial decline from previous level of functioning in one or more of the core areas of cognition, which are listed here, just like on the previous slide: executive function, learning and memory, perceptual motor abilities, social cognition, and judgment. They're so sufficient or so severe that they are sufficient to interfere with activities of daily living and independence. And as you see, they do not occur exclusively in the context of a delirium, and they're not attributable to another mental disorder, for example, major depressive disorder or schizophrenia. have been around long enough to remember the use of the phrase pseudo-dementia of depression, where we might see an older person who is so depressed that if you didn't know better on first exam, you might think the person had a cognitive disorder. So unique features here include this very slow, insidious onset. So dementia comes on over the span of months and years. The course for most dementias is slowly progressive. There are some that are static, but I won't go into that, different etiologies, but most commonly things like Alzheimer's disease, Parkinson's disease with dementia, Lewy body dementia, etc. The course is progressive over years and years. The altered mental status is their baseline. This is consistently how they are. And relative to delirium, hallucinations and delusions are less likely until later on in the course of the disease. Speaking very generally, that's kind of a rule of thumb, but it's not 100% set in stone, but it is something to think about in the overall calculus of things. So I've included here just a kind of an illustration. As I say, sometimes these things happen at the same time, one on top of the other. So this is just kind of an illustration to draw attention to the notion of delirium superimposed on dementia. And, you know, in the center, you see a red area where they overlap, noting that delirium symptoms can overshadow the dementia, can make them worse. So the person is even more disoriented, even more forgetful than they usually are. It gets especially difficult, and I would definitely consult a specialist if you've got a person who has Lewy body dementia, because that already features some of the features of delirium, except it's the person's baseline. It's not a change. But those folks can develop a delirium as well. And so that especially is a time to get very meticulous in making that differential diagnosis. For example, we know people with Lewy body dementia are meticulously sensitive to certain medications that might get used, say, for example, for hallucinations that could be toxic for them. So I specifically identify Lewy body disease as a unique culprit here. It does differentiate dementia from delirium again in graphic form here. So the gradual onset for dementia versus acute onset for delirium. Attention will often be more intact in the earlier stages of dementia versus delirium, where it goes offline pretty immediately. And each is a risk factor for the other. Just to make it extra complicated, having dementia raises the risk of getting delirium, and having had deliria, especially repeated bouts of deliria, is a risk factor for ultimately down the road developing a full-on dementia syndrome. And so this is just a summary slide that I appreciate the Downing article. It's kind of an oldie but a goodie. I just find this kind of a helpful chart, and it makes the point that you know, some degree of a lot of these symptoms may be present in really any one of the 3Ds. Sometimes what we're looking at is not so much presence or absence as much as how predominant something is. So, for example, you can have people with depression who have some trouble with memory, but it's not nearly as predominant as it is, for example, in Alzheimer's disease or delirium. So sometimes it's a matter of present or not present. So, for example, people who have a depressive episode are not going to be disoriented and to person, place, and time, for example. So sometimes it's a matter of present or not present, but a lot of times it's a measure of to what degree, what's more predominant and what's more likely versus less likely. So I like this chart because it sort of helps draw attention to that. So with that being said, these are some of the resource articles I mentioned. There's some information here, including for providers, but also for families. I'm a big believer in educating families about delirium proactively. So they know, be on the lookout for this. There is no such thing as mom's dementia. It's just so much worse in the last couple of days. That's not just a bad day with dementia. That's its own separate beast that we have to take on. So there's some patient information stuff here. There's information for providers. And then the last two articles are the subjective experiences addressed of having delirium, and also the subjective experiences of having someone you love have delirium. I'm a big believer that we take care of a lot of people for a lot of different syndromes, but how often do we ask that person, what's it like to have this thing that we're treating you for? How does that affect your life and your personhood? What's it like going through that for you? We don't ask that a lot, and so these two articles did, and I just appreciated that very much. So they're in there.